Any scar tissue I can get rid of. All right. That should do it. Oh, Luis.
Yes, sir.
Our last patient was wondering, can he come in tomorrow morning, 7:30, and get his staple out? Because he's got to catch a flight back to Louisiana. Yeah, the last patient was actually from Louisiana, right? Yeah, he's doing phenomenal. Yep, no pain. He's from Louisiana. This one's from Naples. And the next one is from, where do we say? Washington. Man, I'm bad today. Just got so much other stuff on my mind, but. Have you guys ever been to Naples? It's beautiful. I think that's clogged, Luis. Clogged. Naples, Florida, really nice. Clogged? A little bit? All right, great job. That's nice and clean. We're done on the left with the DLDR. So I'm going to do the DPR, correct?
Yes,
Left side, everyone agrees?
Yes, sir. L4-L5.
L4-5. Come on, bring that forward in. Let's stay in the AP configuration. Let me know when you're ready. You're going to need to bring it up to the top. Up, up, up. Left 4-5. Wait. Sure, shot. Is that it? All right. So that's 4-5 there. Wait, do not shoot. She has a little scoliosis, so it makes it a bit challenging. Shot. All right. I need to see my side, Monica. Do you understand? My side. Shot. Okay. Definitely on the TP, I feel it. I need to go a little more medial. Shot. Shot. Is that it? Shot. All right, Luis. That's what we need to numb up. Go ahead. Knife. All right, at this point we're going to perform what's called the Deuk plasma rhizotomy, which is where we kill the pain nerve that is sitting on the facet joint at L4 and L5. Now I picked the L4 and L5 shot, and I could be wrong. I hope I'm not. But shot, there's always a possibility when you're picking facets, shot, that you could be wrong. Is that it? Shot. Huh. So she's got some scoliosis, which makes it a little harder for me. Shot. Man, it looks like kind of an abnormal transverse process, doesn't it? Shot. 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 So you can see the pedicle, and I'm just lateral to it. But it's an abnormal shot bone, very abnormal. It's not shaped normally. Shot. It's pretty damn good. You guys see how small the transverse process is? It's like a little thing. It's insane. I didn't realize how many abnormal transverse processes people have until I started treating this condition more by itself, you know, shot. I'm literally on the edge of that thing, and it's so abnormal. All right, and we're going to go down to L5. Move your hand, shot. I need to see the bottom a little bit better. L5. Shot. Not really, but shot. I can see the TP right there. Shot. Now right on the transverse process, so I'm right where the nerve normally runs, the bad nerve, the pain nerve. So definitely in the right spot. This, you guys see the transverse process here? It's a lot more normal looking. Shot, you guys saw it down there? It's just the L4 transverse process on the left that's totally weird. Even the one above is normal. So, all right, put pressure. Great, we're done with the DPR. We're gonna move back to the endoscopic DLDR, which is the disc treatment on the right side. We got 3 more to go and we'll be done. This will be 30 minutes. Shot. Wait a sec, did that needle come out or not? Shot? No? Shot? Okay. Starting at the bottom.
Yeah.
Shot. No problem. Any comments, questions?
Yes, we have a comment and a question. This first comment comes
Shot.
from Canes25 on YouTube.
Sounds good. Go ahead.
They said, Doc, look up Codex Alimentarius, UN resolution signed years back to backdoor us and GMO on all vitamins and minerals out of food. I don't know.
I don't know that I understood that comment.
I'm trying to understand it too.
Something about a codex of food or something?
Yeah, Codex Alimentarius, UN resolution signed into law years back to back, door us and GMO all vitamins and minerals out of food.
Oh, right. I think I understand now.
Okay.
Take that. Take it out. All right, so a lot of people talk about how hammering this metal device into the patient is freaky, which I understand, I get it. When I first saw it, I thought it's the craziest thing I ever saw. But now that I've done it for years. It doesn't mean that I've become crazy. It just means that I understand the purpose of it, and it is to deliver energy to this metal tube in a quantifiable manner that's not going to put too much energy at one time.
The patients are deeply asleep, so they have no recall, no sensation of pain.
Yeah, the patients are unaware of it, but until they watch the surgery, and then they freak out again. But from a standpoint of delivering the device into the disc safely, it's the safest way to do it. Grab her. Grab her. All right, why don't you take care of that side while you're waiting, if you can. Luis, take care of that side when you get a chance, if you get a chance. You're going to do staple or suture? I mean, that seems to be working, right? Why not? I mean, what are your thoughts? Because they all come back in the next day, and you can just take it out, and you can put a steri strip. I agree. So just the staple and a bandage. And then tomorrow we'll put on a steri strip. I like it. We're constantly refining our technique here at Deuk Spine by very creative people like Luis, Dr. Berndes, my nursing staff. Everybody is contributing ideas to make things better for the patient, and I love that. It's a team approach. You don't find that everywhere. As a matter of fact, I don't remember seeing it all in my training. Everyone is just so to themselves and not really a team, you know? There was really no creativity. You know, I'll tell you a funny story. When I was a neurosurgery resident at the University of Florida in Gainesville, one of my attendings was Dr. Arthur Day. He was preeminent neurosurgeon in the world. There's your tear right there. You guys see the tear? See how the herniation is stuck on it? Anyway, we were managing patients with subarachnoid hemorrhage from aneurysmal hemorrhaging, and we were clipping aneurysms and doing all kinds of stuff like bypass and coiling. We were doing everything back in the late 90s, early 2000s with Dr. Day. And I remember as a resident in 97, we had these patients who had aneurysmal bleeds in their brain, and they would all develop hydrocephalus, which is called a communicating hydrocephalus, where the blood would clog up the drain in their brain that drains out fluid. And you know, you produce 3 cups of fluid a day, and then they wouldn't be able to drain 3 cups, they'd drain 1 cup or 1.5. So they would accumulate fluid within their subarachnoid space. And the treatment back then was to do a lumbar puncture, to go in and stick a needle in their spine, clean up their back, stick a needle in there and drain out as much fluid as you could. But what happened was it would decompress the cisterns quickly, and they could get a subdural hematoma complication. They get meningitis, all this bad stuff. So one day I said to Dr. Day, why don't we put in a lumbar drain and drain the fluid that way? That way you don't have to keep sticking a needle in. And he said, no, you can't do that. Well, turned out that's now the standard of care, right? So, but the problem is, for whatever reason, maybe because I was just a junior resident and an intern, just fresh off the boat, they just didn't think that I could possibly have any ideas. But they kind of stifled creativity. And progress in medicine requires creativity. Not just any creativity, but intelligent creativity. And it was not something that was fostered at my program at all. As a matter of fact, when I began to do the endoscopic spine surgery After I graduated, I learned from the Koreans and from Germans and Dr. Young over in Phoenix. I went back and tried sharing this with my team, the neurosurgeons that I trained under, and trying to get them to adopt endoscopic spine surgery, but no way. They weren't going to. They were too set in their ways. It's unfortunate. All right, just about done with this disc. Done a nice job of cleaning it out. There's a little more bleeding, you saw that. The bleeding is because we've already done the other side, and the other side still has a little bit of blood that was coming into the disc and coming through the disc and up my side. Remember in the beginning I showed you the blue dye in the needle on the left that from the injection on the right? So we injected blue dye on the right, but we could see it in the needle on the left because it went through the disc and came up the other side. Well, the bleeding from the left side that we already did is coming through to the right side. So it's very common. It's nothing I'm concerned about. But boy, this is nice though. The blue dye is really nice here. I gotta say, Luis, very pleased. It's really done a good job of identifying the herniation. Yeah. Oh, I don't, no, I'm fine. Thank you for asking. It's very kind of you. Black coffee? I'm gonna make some black coffee when I'm done. Literally, I need some coffee. We're just about done here. I've got 2 more discs to do. We're done with this one. Look at that tear, it's massive. Good thing she had this done. I think she's gonna be really happy with the results. This will all heal beautifully now that we've gotten the herniation out. And people ask me, you know, did you get all the herniation? No, we're never gonna get all the herniation, okay? We're never gonna get all the herniation. No doctor can get 100%, and I don't try to get 100%. I've accepted a long time ago we're not going to get 100%. We're going to get at best 80%. Maybe once in a blue moon we'll get 90%. But the point is to get 50%. If you can get 50% of that herniation, you're going to make that patient feel so much better, and it'll last. As long as they don't re-herniate. Done. No, that has to be redone.
Yeah.
We have a question.
Of course.
This comes from B3 on YouTube.
Hello, B3.
They ask, how long does it take for the annular tear to heal? Will a new nucleus be produced by the body to replace the dried out or depleted ones? Great
questions, B3. So to answer your questions, it takes 1 year for the annulus to heal, to get to 100%. And the nucleus will never regenerate. The nucleus comes from something called the notochord, which is an embryological structure found in the fetus, and it disappears and becomes the nucleus pulposus. I got this. You focus on your thing. So basically, to answer your question, the nucleus pulposus comes from something found in the fetus or embryo that, once it's goes and becomes the nucleus pulposus in the adult, you can't make any more. So, the thing about it though is that you don't need nucleus pulposus. Everyone thinks they need a tall disc, a high disc, a normal disc. You don't. There are millions of people with completely collapsed discs and no pain, no radiculopathy, no symptoms whatsoever, and they lead completely normal lives. So that's really what the goal of treatment is to get people asymptomatic. It's not to make their disc look normal, but there's a lot of misinformation out there unfortunately, about the disc. And that's what we try to clear up here at Deuk Spine. Oh, shot. Yeah, north, please. You're way off. I mean, you should be farther north. You're way off on the WAG, too. Shot. Shot. Yeah. So what I've done here, I bent the needle going into the disc, and you can see that on the x-ray, and it's just hard for me to get the needle out because it's sticking on the guide wire because of the bend. Anyway, we're getting it. So you just got to be careful when you do this stuff. You got to keep getting x-rays to make sure. Look how bent that is. You guys see that, Henry?
Yes, we do.
Yeah. So it's okay to bend the needle. It's not a problem. But you don't want to pull your guide wire out accidentally before your needle's completely out and you've done your dilator. So just got to keep taking pictures. Come on, Monica. How's she doing?
Great.
So we're done with most of the surgery. We're almost finished. Just got a little bit more to go. So to answer your question, discs do not regenerate except for the annulus will. The annulus is the only part of the disc that can heal. And the nice thing about the annulus is that it's made out of collagen. So when it heals with collagen. So the same thing it's made from. It's one of the only tissues in your body. As a matter of fact, probably the only tissue in your body that actually heals with the same material it's made from, which is collagen and some elastin. Like if you injure your liver heals with collagen. If you injure your muscle heals with collagen. Everything in your body heals with collagen except in your brain, where it doesn't heal with collagen, because you have a blood-brain barrier. Anyway, every other tissue heals with collagen. It turns out the annulus is made out of collagen, so it's kind of interesting. All right, you see the big tear? Let's get the laser in. The grabbers aren't doing anything. I need a pedal. Thanks. You can see the frayed edges of the annulus there. We got this disc and one more to go. How's our last patient doing? Oh, that guy? No, I mean the one that has still yet to go. She must be hungry. Feel bad. Yeah. The one from Washington. the real patient from Washington. Give her a little vitamin H. Oh yeah? Nice. Yeah. Yep. Well, that's how we take care of our patients. We want them feeling good. All right. Piece of herniation coming out. Any questions from our audience, Henry? You can see the tear. All right, so Henry is taken off for a quick potty break, and if you have questions, you can still type them up, and when he gets back, he'll ask me. But you can see the orange spots. That's calcium. That's the development of bone spurs. We call it dystrophic calcification. This stuff is located inside the disc, and it's an indication of chronic inflammation, meaning inflammation going on for a long time. It's kind of pretty if you think about it. If you ask me, I think it's pretty. But it's totally abnormal. Should not be there. Doesn't cause any symptoms. It's just a manifestation of injury to the disc and chronic inflammation. Some people have more of it than others. There's no real rhyme or reason that I know of. I will tell you, you never see the orange calcification in a newly herniated disc, so it kind of ages the injury. Now, she said earlier she had 7 months of pain, but I think that's 7 months of new onset of pain. She's had pain for years, like most people with back pain, and she's just lived with it, treated it with shots. Nothing really worked. And then 7 months ago, I think things got real bad, and it hasn't gone away. So that's why she ended up here, getting her back fixed, which I think she's going to be happy. What a lot of people don't understand is when we fix people's backs or necks, we're not fixing your back or neck so that you can just sit around and baby it all day. It's not like we're fixing it and your pain goes away, but as soon as you get active, it's going to come back. That's not how it works. We're fixing your back and neck pain permanently. So 1 year after surgery, you can go back to doing everything you want to do in life. You can go whitewater rafting. You can go bungee cord jumping. You can go kayaking. You can do anything and the pain will not come back. So we're not just taking pain away, we're giving people back their quality of life. And there's a big difference, right? There really is a big difference.
I'm back.
All right, welcome back, Henry.
Thank you for having me.
Yep, all right, just about done. You can see we're at the back of the disc here. We got one more to go and we'll be finished. So probably 15 minutes, Dr. Berndes.
Speaking of, we do have a comment. This comes from Hans Berndes on Facebook.
Ha! Nice.
And Hans said, world's greatest spine surgeon.
You're the best. I appreciate that. Thank you. Thank you. That's coming from my anesthesiologist. I really appreciate that. All right, just about done here. She's doing good?
Yeah, really well. Great blood pressure, good vitals.
You using the thing?
No,
CPAP, whatever?
easy on next case.
All right. Everyone doing good? That should be it. All right, one more. A little betadine. Irrigation. Let's get that fluoro in. Everything okay?
Yeah, you definitely go through it.
You may have to raise your floor a little, I don't know. You guys doing all right over there? Last one. Here's a long one. All right. Go ahead, Luis. What's the next one?
It's a piriformis with a DPR in it.
All right. Shot? Is that it?
I was just checking.
Take? That's fine. She's perfectly capable. Shot? Shot? 5, 4, 3, 2. You can still see some of the dye. It's interesting because you kind of wonder how long does the dye stay in the disc, right? And at least a couple hours.
We have another question.
Uh-huh.
This comes from B3 once more on YouTube. And they asked, have you ever had a patient come back due to a herniated disc? Do you put someone on a regimen to prevent this, such as supplements, drugs, routine exercise, etc.? And does swimming help? If I am lucky to have this done, I will have my life back. I am from Nigeria, by the way.
Oh, hello, B3 from Nigeria. Yes, we give restrictions after the surgery, and those restrictions are no bending at the waist to pick anything up for 3 months, no lifting more than 40 pounds for 1 year, and no contact sports for 1 year. That's your restrictions. Is there an exercise regimen? Absolutely. We do not want you, we want you walking daily with arm swing for 20 minutes twice a day, first 2 weeks. And then after 2 weeks, you increase to once a day for a mile, and try to get your mile under 15 minutes. That is the regimen for therapy. You don't need to go to a physical therapist. Just do it on your own. And as far as reherniation, absolutely, 1% of our patients will reherniate, 1 in 100. So we've done over 1,600 of these surgeries. We've had 16, basically 15 reherniations. So now, we haven't had many in the last few years because people actually are following my instructions and they're doing what they're supposed to do. They're not violating my restrictions. But once in a while I have people that do violate the restrictions and they do have a reherniation, but it's rare. As long as you follow my instructions, you won't have a reherniation. The people who reherniate from this surgery always reherniate in the first 3 months, and it's always because they lift something too heavy or they bend over and pick things up. They all say the same thing. Oh, I heard a pop in my back. I felt a pop in my back. A pop, like a loud pop. And that's the reherniation. Of course. But the people who follow the instructions, they never reherniate. Nice. Remember that earlier case? My gosh, we fought that herniation for a long time. Remember that? Yeah. 2 levels, one side, and then DPR. Well,
We need to order stools, like a bar stool.
yeah, get it. We need not bar stools, we need a massage stool so that we can sit down and get a massage while we're operating. By the end of the day, we need a foot massage, a back massage, right? Oh yeah, something you guys don't realize maybe is that we all wear lead here in the operating room. Lead is lead. It's a lead apron, a lead gown. It's very heavy, and it sits on our back and shoulders all day. Because when we're this close to the radiation machine, the x-ray machine, we have to protect our bodies. So you're right, I didn't even think about that. We're sitting in lead all day. It's very, very heavy. All right, I got 5 minutes. We're done. So folks, this is our last chance to get some questions for the surgery. I'm going to have Henry end the broadcast. We're not going to do the typical QA because frankly we're all peaked and we need a break. So if you have questions, ask them now. We do have one more surgery today for those of you who are really diehards. We got one more to go. And we'll be back answering questions.
This next one is a comment. I believe they're seeking for advice. This comes from Myra on YouTube.
Hi Myla, welcome to our broadcast, live stream from Deuk Spine.
And I apologize. Their name is Mario. Apologies for that.
I'm sorry.
Yes, no, they said it in their description. They said, hello, my name is Mario from Los Angeles. I'm 35. I've had chronic back pain for 15 years. My back pain keeps going out / spasms for about 3 times a year. I'm told it's caused by my herniated disc, but I have no sciatica.
Hi Mario, you do not need sciatica. We can fix your back pain. We can fix it as soon as you come here with this surgery, Deuk laser disc repair. Okay? So come on over. You can do an MRI review if you'd like. Just submit your MRI for me. 1 minute. Just about done. Yes, we can fix your back pain. It is coming from the herniated disc, and this is the perfect surgery. It's done with a small incision, outpatient, no hospital, no fusion, no blood loss, very safe, very effective. No, we're done. How much you have left on that bag? That's fine. We're done. This is it.
We have one more question. This comes from Teak on YouTube.
Hello, Teak. Welcome back.
And
Is that Teak Baker?
I think so. It just says Teak on, and yep, on YouTube, and they just asked, is Dr. Berndes with you today? You guys are a great duo of physicians.
Yes, Dr. Berndes is still here. He hasn't ran away yet. Dr. Berndes loves what we do. I don't think he's going anywhere. 2 years? Has it really been 2 years? Man, time flies when you're having fun. Yeah, Berndes is right here. He's actually gotten really good at doing these surgeries. And we've been kind of pioneering a new way to do them using a CPAP machine, which really helps keep the patients well ventilated during the surgery and cuts down any kind of obstruction of the airway. So it's kind of neat. I don't know why I'm having so much trouble. All right. All done. Hope you enjoyed the surgery. Great to hear from you, Teek. Can't talk about that. So today we're using some staples just because we want to try this out and see how it works. And we'll get them out tomorrow when the patient comes to us for their post-op check. Great work, everybody. You can see we had to do 2 little cuts. Thank you, everybody. Good work. And we'll be back in 30, 45 minutes for our last surgery. It will be our shortest one, thank God, on an otherwise very long day. All right. Good job, everyone. And Henry, if you want to just end the feed, you can.